Good evening, ladies and gentlemen. We are back again with another exciting evening of No Thrombosis workshop series in acute ischemic stroke. I am Ananda Singh Rathore from the MCure Pharmaceuticals marketing team, and with me is also Dr. Onkar Swami, who is the medical director, MCure. On behalf of MCure Pharmaceuticals, I take this opportunity to welcome you all for today's event. We at MCure are highly privileged and honored to have with us the expert neurologists from across the country supporting us and guiding us in this academic initiative. Without much ado, without much ado, I would like to introduce the faculty members for today's evening. As you all are aware, our post director for this series is Dr. N.R. Ichhapuria sir. Sir needs no introduction. Sir is Director Neurology at Sahyadri Hospital, Pune. Sir has been instrumental in setting up the first neuro ICU and starting neuro intensive care as a specialty in the city of Pune. He has been a pioneer in thrombolysis treatment for stroke in India, having done the first thrombolysis and having then done more than 1,000 IV and IA thrombolysis. He set up the first stroke unit in Pune city. Sir is an avid public speaker in the field of stroke and neurology with more than 300 public lectures and workshops on stroke. He has been an invited speaker for numerous conferences and has been a preceptor for stroke thrombolysis all over the country and abroad. Sir was recently awarded as Health Icon by the Times of India Group. Welcome for the event, sir. Our first guest moderator for the day is Dr. Pramod Krishnan. Sir is consultant neurologist and epileptologist, head of the Department of Neurology, Manipal Hospitals, Bangalore. Sir is a certified specialist in sleep medicine. Sir has special interest in epilepsy, sleep medicine, multiple sclerosis, and neuropathy. Sir has received gold medal in his DM neurology and has been awarded the best outgoing student in NIMHANS. Sir has several publications in national and international journals, 29 publications to be specific. Welcome, sir, for this program. Our second guest moderator for the day is Dr. Sunil Garcia. Sir is consultant neurologist, Garcia Hospital, Jalgaon. Sir is an expert in treating all kinds of neurological disorders, including stroke, vertigo, dementia, movement disorders, headaches, etc. Sir was the best outgoing student during his DM neurology from NIMHANS, Bangalore. Sir is a member of the American Academy of Neurology and the president and founder member of Maharashtra Association of Neurology. Our first speaker for the day is Dr. Lieutenant General C.S. Narayanan. Sir is head of Department Neurology, Manipal Hospitals, New Delhi. Sir did his DM neurology from AIIMS in 1998. Sir was part of the team that performed the first deep brain stimulation procedure for Parkinson's disease in the armed forces in the year 2000. Sir has a unique distinction of being awarded the Vishish Seva Medal for Distinguished Services by the Honorable President of India 3 times in the year 2009, 2014, and 2015. Sir has been the Chief of Army Staff Commendation twice in the year 2002 and 2007. Sir has been conferred with the Capital Foundation National Award in October 2014 by the Honorable Chief Minister of Odisha. Sir was appointed as Honorary Surgeon to the President of India on 25th July 2017, and he has also successfully steered the implementation of a nationwide network of telemedicine solutions in the Army, Navy, and Air Force. Welcome on board, sir. Our second speaker for the day is Dr. Tanmay Thombare. Doctor is consultant neurologist at Aster Aadhar Hospital, Kolhapur. Ma'am has 4 years of experience as a neurologist. Ma'am has clinical expertise and interest in managing stroke, epilepsy, neuromuscular disorders, peripheral neuropathy, and neuroinfections. Ma'am secured 3rd rank in DM neurology from the Rajiv Gandhi University of Health Sciences and also won the Dr. A.K. Roy Award from St. John's Medical College, Bangalore. With this, I would request request the course director and the moderators to take it up from here to share their thoughts, and we can get started with the first presentation by Dr. C.S. Narayanan.
Thank you. Thank you very much for all the kind invitation and the kind words. And I think this is the 7th in the course. And we've had some absolutely dramatically wonderful cases in the last few. the courses that we had. And I'm sure today will also be very exciting. And many people have benefited from this, the courses that we had. Without much ado, I request General Narayanan to present his case.
Thank you so much, sir, and good evening to everyone. And thank you, Team MCure, for inviting me to participate in this session. I'll just share my screen. Yeah, so I have kept the title of my topic as "Is it time to switch?" And I think this question is bothering a lot of us, because a lot of evidence is created on the basis of very well conducted studies. And as we all know, we are all used to using Alteplase so far, but the time has come to switch possibly. And I will present some evidence, and maybe some people will change their mind as well. So to begin with, this is a very simple slide, but I think it's good to set the ball rolling. That what is the fibrinolytic system? There are two parts to the fibrinolytic system. One is the intrinsic system, where you have a single chain urokinase-like plasminogen activator, which gets converted by kallikrein into UPA, and this acts on plasminogen and converts to plasmin. And plasmin finally acts on the fibrin clot and converts them to fibrin degradation products. And the extrinsic system, which works through the endothelial cell, works through TPA and works on the same mechanism of converting plasminogen to plasmin and converting the fibrin clot to FDP. I think this is a very important thing to understand to begin with. So as we all know, the US FDA approved recombinant tissue plasminogen activator, which is also called Alteplase or Actylase, for the treatment of ST elevation myocardial infarction in 1987, and later for the treatment of acute massive pulmonary embolism and for occluded sedentary venous catheter. It was only approved in 1996 for the use in acute ischemic stroke, and we all know about the NINS trial and the ICAS trial, and we don't have to speak much about it now. However, there have been some concerns like serious bleeding complications, especially intracranial bleeding, and also a limited recanalization rate and rapid clearance requiring an infusion with Alteplase therapy, and this motivated the development of thrombolytics with more desirable properties. Because of the very short plasma life of Alteplase, a gap between the end of the bolus and start of the infusion will result in underdosing. Actually, this is a very important point, and unless this is kind of drilled into our emergency medicine team or the first responder teams, if they assume that after the bolus they can sit quiet for a few, half an hour or so and start the infusion later, it will be absolutely suboptimal therapy. So now we have this new kid on the block, and mutagenesis studies produced a variant of Alteplase with 14-fold greater fibrin specificity and a 10-fold conservation of fibrinogen, and the 80-fold increased resistance to plasminogen activator inhibitor 1, and this results in more thrombolysis and reduced plasma clearance. So we are talking, of course, about tenecteplase. And tenecteplase, as we all know, is a recombinant TPA. It is a thrombolytic agent which is more fibrin specific and has a longer duration of action compared with Alteplase, permitting the convenience of single bolus administration. And what is the evidence for its use? Although no single trial has prospectively demonstrated superiority or non-inferiority of tenecteplase on clinical outcome, meta-analysis of these trials point to the superiority of tenecteplase in decanalization of large vessel occlusions and non-inferiority in disability-free 3-month outcome without increases in symptomatic intracranial hemorrhage or mortality. So I will briefly run through some of these landmark trials to suggest that we have accumulated enough evidence for us to change our thought process. To begin with, I will start off in the reverse order by talking about the latest guidelines of the American Heart Association, American Stroke Association, which was published in 2009. And we'll first go through what they have to say about the use of tenecteplase. So here, the recommendation is that it may be reasonable to choose tenecteplase single IV bolus of 0.25 mg per kg, a maximum of 25 mg, over IV alteplase in patients without contraindication to IV fibrinolysis and who are likely to undergo mechanical thrombectomy. So this is a strong recommendation and with adequate basis on clinical trials. And the second recommendation is that tenecteplase administered as 0.4 milligram per kg body weight single IV bolus has not been proven to superior or non-inferior to alteplase, but might be considered as alternative to alteplase in patients with minor neurological impairment and no major intracranial occlusion. There have been some trials to counter this argument. I'll come to that later. It also says the administration of other IV defibrinogenetic agents and IV fibrinolytic agents other than alteplase and tenecteplase is not recommended. That obviously implies that tenecteplase is recommended. When was the first salvo in this direction fired? It was on the basis of a randomized trial of tenecteplase versus alteplase for acute ischemic stroke. This was published with Parson et al. In NEJM as way back in 2012. They randomly assigned 75 patients to therapy with either alteplase in a standard DINS trial dose of 0.9 milligram per kilogram body weight, or tenecteplase 0.1 milligram per kilogram or 0.25 milligram per kilogram. So they used tenecteplase in two doses and compared the two as well. And they included all patients who were less than 6 hours after the onset of ischemic stroke. So they had 3 treatment groups, each comprising of 25 patients. The mean NIHS score at baseline for all these patients were around 14.4, and the time to treatment was about 2.9 hours. Together, the two tenecteplase groups had greater reperfusion and clinical improvement at 24 hours than the alteplase group. So they've also demonstrated that there is early benefit as well, in addition to the benefit which is seen in the MRS scores at 3 months. There were no significant between group differences in intracranial bleeding or other serious adverse effects. The higher dose of tenecteplase, 0.25 mg per kilogram, was superior to the lower dose and to alteplase for all efficacy outcomes, including the absence of serious disability at 90 days. This was quite substantial. They found this in 72% of patients versus 40% with alteplase, which was obviously statistically significant. Now, there is another trial, which was the original trial called the NORTHPRESS trial, where they included 1,100 patients, but in this trial, most of the patients had very minor strokes with a median NIHS score of only 4. The tenecteplase group treated with 0.4 milligram per kilogram had similar safety and efficacy outcomes compared to the alteplase group. Then we come to another important trial, which is called Extend TNK, which was published by Campbell et al. In the NEJM in 2018. It was titled tenecteplase versus alteplase before thrombectomy for ischemic stroke. So in this study, they randomly assigned patients with ischemic stroke who had occlusion of the internal carotid, basilar, or middle cerebral artery and were eligible to undergo thrombectomy to receive tenecteplase at a dose of 0.25 milligram per kilogram body weight, maximum dose 25, or alteplase in the standard dose within 4.0 hours of symptom onset. The primary outcome in this trial was reperfusion of greater than 50% of the involved ischemic territory. So of the 202 patients enrolled, 101 were assigned to receive tenecteplase and 101 to receive alteplase. The primary outcome occurred in 22% of the patients treated with tenecteplase versus 10% of those treated with alteplase. So this is just a graphic to depict what I just said. So there is a substantial difference in the reperfusion rate of greater than 50% of thrombectomy before an angiogram done before thrombectomy. It was 22% in the tenecteplase group and alteplase. There's also a substantial difference in the 90-day functional outcome seen with the modified ranking score. It was only 2 in the tenecteplase group compared to 3 in the alteplase group, signifying better functional outcome. So now we come to some meta-analysis, and this is the basis. Like I said, no individual trial actually has prospectively demonstrated the superiority of tenecteplase or alteplase, but pool data of 5 major randomized trials goes in that direction, and investigators have published 5 randomized trials of tenecteplase versus standard dose alteplase, 0.9 milligram per kg for ischemic stroke, compared with different doses of tenecteplase and their effect on early outcomes of recanalization, reperfusion, and substantial neurological improvement, as well as symptomatic intracranial hemorrhage and a 3-month disability on the MRS. So all relevant parameters of both efficacy and safety were studied. So the one important trial was a meta-analysis was published in Acta Neurologica, and I included this because Dr. Kameshwar Prasad was one of the co-authors of this study. But the more widely quoted meta-analysis is published by Adrian Burgos in Stroke in 2019. And the title was Evidence that tenecteplase is non-inferior to alteplase for acute ischemic stroke, a meta-analysis of 5 randomized trials. So this is a brief summary of the trials included, which included TNK S2B, the Australian tenecteplase study, the ATTEST, the NOT test, and the Extend TNK. The last 2 I just alluded to in slightly more detail earlier. So in this meta-analysis comprising of 5 trials, they enrolled 585 patients. 828 received tenecteplase and 757 received alteplase. The mean age was 70.8 and 58.5% were males. The mean NIHSS score was 7, and the mean time from last known well to onset of treatment was 148 minutes. The alteplase dose was 0.9. This is standard across all the trials. The tenecteplase dose in this meta-analysis varied from 0.1 to 0.25 to 0.4. The primary endpoint of the meta-analysis was MRS of 0 to 1 at 3 months, which was achieved in the tenecteplase group by 57.9, whereas it was achieved by alteplase group at 55.4. Safety endpoints were also consistent with non-inferiority. So the meta-analysis definitely pointed to non-inferiority, if not benefit. So the accumulated clinical trial data provides a strong evidence that tenecteplase is non-inferior to alteplase in the treatment of acute ischemic stroke. These findings provide formal support for the guideline recommendation to consider tenecteplase as an alternative to alteplase, and this was, of course, suitably incorporated in the AHA guidelines as well. However, the caveats, we went on to the second part of the Extend TNK trial, which was titled Effect of IV tenecteplase dose on cerebral reperfusion before thrombectomy in patients with large vessel occlusion ischemic stroke. So here they used a higher dose of 0.4 mg and they compared it with the 0.25 dose to improve cerebral reperfusion prior to endovascular thrombectomy in patients with large vessel occlusion. So they wanted to compare and find out which is better. So in this randomized trial that included 300 adults, the percentage of achieved substantial reperfusion prior to endovascular thrombectomy was 19.3 in each tenecteplase dose group with no statistically significant difference. That means both of them were equally effective. The findings suggest that 0.4 mg dose of tenecteplase does not confer any advantage over 0.25 mg dose in patients with large vessel occlusion ischemic stroke. So this is one point answered, that the higher dose does not confer any benefit. So we will come to the subsequent part about safety now. So another trial which was conducted, which is follow-up to the first NORTEST trial, was the NORTEST 2 trial. Here they compared tenecteplase with the alteplase for the management of acute ischemic stroke in Norway. This was a phase 3 randomized open label blinded endpoint non-inferiority trial, which is published this year only in Lancet Neurology in June 2022. So they included patients with moderate to severe ischemic stroke, as against the first NORTEST trial, which included patients who were much less sick. Their average NIHS score was only 4 then, but here it was a more sick population with the NIHS score of 11. And these patients were also within the 4.5 hour window of stroke onset. They were randomly assigned to the higher dose 0.4, and this was compared against alteplase in the standard dose. At 3 months, compared to alteplase group, the tenecteplase group showed a trend towards an increased rate of symptomatic intracranial hemorrhage, which is substantially higher, 6 versus 1%. So the trial was stopped early after enrolling only 204 patients due to high numbers of symptomatic intracranial hemorrhage in the tenecteplase group. So we first saw that it was not more effective the higher dose, and we also saw that it is harmful. So now there is more clarity on the optimum dosing of tenecteplase. Higher doses of tenecteplase should not be used in intravenous thrombolysis because such doses may be associated with harm. So now coming to the guidelines, I started my presentation with the ASA guidelines. And what do the other guidelines say? The 2018 European Stroke Organization guideline recommended against the routine use of tenecteplase in clinical practice. But an update the following year indicated that 11 experts recommended tenecteplase over alteplase in large vessel occlusion patients if the decision on IV thrombolysis is made after vessel occlusion status is known. So those patients who are undergoing mechanical thrombectomy in whom the vessel pathology is studied angiographically, we can use tenecteplase. And this was presented in the ESO Karolinska Stroke Update Conference, Stockholm. The 2019 Australian Stroke Foundation gives the two drugs equal status for large vessel occlusion and tenecteplase as an alternative in other strokes. So they go one step forward, and this has also been published in their guidelines. So in conclusion, although still not licensed in the US for IV thrombolysis in acute ischemic stroke treatment, there is moderate to high quality evidence that intravenous tenecteplase given in a single bolus of 0.25 milligram per kilogram with a maximum of 25 milligrams has similar efficacy and safety outcomes compared with alteplase, including rates of excellent functional outcome, symptomatic intracerebral hemorrhage, and mortality at 90 days. So to summarize briefly the differences between alteplase and the tenecteplase, alteplase is also a recombinant version of the naturally occurring tissue plasminogen activator, but it only binds semi-selectively to fibrin-bound plasminogen. Tenecteplase is also bioengineered from TPA. It is more fibrin-specific. It is more resistant to the degradation by endogenous plasminogen activator 1 complex, so it has got a longer action. Alteplase has got a half-life only 5 minutes, and the terminal half-life is only 72 minutes. That is why it has to be given bolus followed by infusion. Whereas tenecteplase has an initial half-life of 25 minutes and terminal half-life which is longer, which is more than 2 hours. Preparation time is approximately 5 minutes for alteplase. It is only 1 minute for tenecteplase. And as I said earlier, we all know that alteplase is bolus per infusion, and this is given a rapid IV push of 5 to 10 seconds. So all the trials, I will not go through them again, have shown either superiority, non-inferiority as far as both the safety and the efficacy outcomes. Looking ahead, there are some ongoing randomized phase 3 trials which may better define the comparative risks of and benefits of tenecteplase and alteplase for stroke thrombolysis and answer questions of tenecteplase efficacy in the more than 4.5-hour time window, and in wake-up stroke. These ongoing trials, there's one called tenecteplase in wake-up ischemic stroke trial called TWIST, and there's one called tenecteplase in stroke patients between 4.5 and 24 hours, which is being labeled as timeless. Before I conclude, I must share some of my experiences with tenecteplase. I have been using tenecteplase for some time, both when I was in the service and in my practice at Manipal Hospital here. But I must confess that so far, my preference has been to alteplase. But having seen all this evidence, I see no reason that I would not be increasingly using tenecteplase in practice, because all the patients that I've used tenecteplase in, which numbers maybe around close to 15 patients, are done equally well. They've had none of the side effects. In fact, many more of the patients that I have treated with alteplase have had symptomatic intracranial hemorrhage. So none of the patients, thankfully, of those patients that I've treated with tenecteplase have had symptomatic intracranial hemorrhage. And all the evidence, and very high quality evidence that we've seen published in the best of journals like Lancet, NEJM, Stroke Journal, have shown that tenecteplase is equally good, if not better. And particularly in some specific subsets, like in those having large vessel occlusions, who go on, for whom we are considering mechanical thrombectomy. And so I'm sure my co-panelists may also agree that we'll all at some point of time veer towards using tenecteplase, which is available in our country. And there has been some commercial issues earlier, because the same company which is marketing alteplase has been manufacturing tenecteplase. And I think there were some issues in their co-promoting both the brands. So that may have come in the way of promoting tenecteplase as first-line therapy in IV thrombolysis for acute ischemic stroke. I'll end my presentation here. And as I requested the organizers, I need to leave, but I'd be happy to take a few questions if there are any before I leave.
Thank you, General Narayan, for a very beautiful overview of tenecteplase. I think you could stay on for about 5 or 10 minutes, yes, sir, sure, if it's okay for questions. Pramod, do you have any comments to make?
Yes, so we've been using tenecteplase now for the last 2 years to a point where it's almost become entirely tenecteplase. Initially, we used to follow the recommendation of up to 3 hours, which was what is approved in India. But the dose approved was 0.2, but we are using 0.25 based on studies done abroad. And later on, we have started using it between 3 to 4.5 hours also, even though that is not actually approved in India. But based on studies abroad, we find that our personal experience also matches with that. We prefer it when there is intervention that is coming up. Our experience in terms of intracranial hemorrhage symptomatic has also been either on par or better than alteplase. So currently, I don't recollect whether we've used alteplase maybe at least for 1.5 years, because it's very convenient and it works out cheaper for the patient. It's much more easy to do in the ER because we always don't have stroke-ready people there. So it's easy to tell the sister and be there and finish it off rather than keep hanging around and monitoring their infusions and everything. So that way it works out well. And when we need to shift the patient quickly to the cath lab for intervention, it's much more easy if it's tenecteplase. And we usually carry it with us to the CT room. As soon as the CT scan is done, and if there is no bleed, and if the patient has a clear story of stroke and is within the window period, is injected right in the CT table itself. And then we do the rest of the processing. So I think the studies have further emphasized and buttressed our current practice of favoring tenecteplase over alteplase, and its advantages are very clear. And it will also probably help in wider use of thrombolysis in stroke at more peripheral centers because it's much more easy to handle and administer. So this is what I have to say, sir.
Yes, Dr. Gajre.
Thank you, Nasmi. When MCure introduced tenecteplase, I was using Altiplase. And I told them, where is the evidence? Where, well, there was none at that time. And in the initial days, I was very skeptical about using tenecteplase. But cost as well as the ease of using it as a bolus dose changed. And as the evidence came on, it has become that in the last 2-3 years, I have not used Altiplase at all. Because Altiplase is much more costlier, a little bit more difficult to administer. And this is one shot bolus and it's over. So I have become a tenecteplase user and I haven't used Altiplase for a long time as far as I remember. I've had one hemorrhage, but that was when I had used the 0.4 dose in the initial days. And I followed the cardiologists who were using 0.4 milligram per kilogram and used it. And that is the time I had one massive hemorrhage and I lost the patient. But otherwise, after I've been using 0.25, the hemorrhage is much less once in a while, and that too a small hemorrhage. So a little bit before the evidence has really come up, I've been using it. I've been using it for wake-up strokes also, and even up to 24 hours. Although the evidence is not there, yet my personal experience is that it is good even up to 4.5 hours, or excellent up to 4.5 hours, and I feel even up to 24 hours when there is a flare and a diffusion mismatch, you can use it. That is my personal experience. I would like to compile all these patients and then make a small series. So I think that is my side of the story.
Yes, I think what all three of you all have said is what is the state of the subject just now. And very recently, just a few months ago, there was this very large trial from Canada done by Bijoy Menon and his group from Calgary called the ACT trial, where it was an RCT and it combined both tenecteplase and alteplase. And they've used the dose of 0.25 and they found it was not geared, it was not, powerful enough to determine superiority, but it has shown that it was non-inferior. So I think the evidence is now pretty strong. And now this large RCT, I think there were more than 2,000 patients in that study. And it was done in the COVID period. And it was across all types of stroke, large vessel, small vessel, lacunar, everything. And both the groups were very beautifully matched and really a very, very good study, Bijoy Menon. And I think it has shown, and the guidelines are still saying 2B, but they will change very soon. I'm very sure that it will change. And another very important point that Dr. Pramod Krishnan pointed out was that because of its use of administration, many more people are using it. And I think as far as I know, correct me if I'm wrong, tenecteplase has been used in 30 to 35,000 patients in India, which is far more than alteplase. So it has been a revolution of sorts, and because of its ease of administration and its fibrin specificity, it has certain advantages, certain definite advantages in the use and administration part, and in its efficacy, it's more or less the same. So it scores over its use, cost in India because it is a biosimilar. The only issue is that we are using the biosimilar. We are not using the molecule in which the trial has been done. That is one little sore point that I have with MCure. that they have not published their data. Though there are 30,000 patients, we ask them for data for 1,000 patients. So they need to provide that data to us. So I implore them, I've been imploring them for a long time, that give us Indian data. I mean, you are using this drug, we are happy with it, but show hard facts. And if you show hard facts, definitely there are advantages. There are definite theoretical advantages. And now, even this big RCT from Canada has shown that it is non-inferior. So there is no problem in using it. And they've used it across the board, for all types of stroke. Of course, there are some special situations like patients on anticoagulant, wake-up stroke, this diffusion flare mismatch. These subgroup analysis has to be done yet. The patients are there. They have not published the subgroup analysis, but very soon I think they will publish this subgroup analysis, and then our confidence level will, and I'm sure it will be effective. But they have to show that it is effective. I mean, it's okay to think that it's effective. You have to show that it is effective. And you have also to show that the biosimilar version is also equally effective. So I think these one or two little niggles are there, but otherwise I think it's caught on very well, and it's been a dramatic success all over the world. Science keeps on evolving, keeps on getting better and better. And till we have a better molecule, which we can give at home or give, as Dr. Gajare said, at 5,000 rupees, till that time, we'll have to use tenecteplase. So that's how the whole circle of science turns. It's a spiral. It's an upwardly growing spiral. It goes round and round, but it goes upwards all the time. So we are very hopeful that new bioengineered products will come, and they will make life easier for all of us, and reduce the risk of hemorrhage, and we can give it at home also without a CT scan, or do something so that even that dot to needle time goes down. And so I think it's been a wonderful lecture by General Narayan, and perhaps he could add this ACT trial, which has been recently published in NEJM, because it's a very solid and very, very good trial. So perhaps you could add that, sir, in your talk, and that will strengthen your case even further. Anything you want to say, General?
As we've all agreed, in India particularly, we are hearing towards the use of tenecteplase, and all of us are very convinced. But I just want to know if someone has any data on how much is it accepted across the world, despite the guidelines across in various countries showing it. Where is the stumbling block? So all of us agree that it is much better, if not much better, equally good and as safe. But why is there a certain level of non-acceptance across the world? Is it only because
that's called
promotion or something else?
That's called pharmaco-economico-politics.
That's what I'm saying. At least we have surmounted that to some extent now.
Yeah, we are the leaders. We are the leaders in this. Actually, we are the leaders. When it first got this thing, it first got approved, I was also a little upset and angry that, how can it be approved without a trial? But over a period of time, we have been proved wrong. At least I've been proved wrong, and I'm very happy to have been proved wrong, because time has shown that it's an effective drug, and somehow the market has taken to it like fire, and so many small places are doing it, and that is all we wanted. Neurologists can't do stroke thrombolysis. There are too few stroke neurologists, and even all neurologists are not doing. Only say 1/3 or 1/2 are doing. So we want physicians to do it. And this is a very nice drug for even physicians to do it, and ER people to do it. So it is a revolution of sorts. So let's hope that it goes on and we don't have any speed bumps on the way, and many more people are benefited by this quite a nice molecule, I must say.
Just one or two comments. General Saab, why the world has not taken it is for 2-3 reasons. One is that insurance companies in the US don't pay for it. They pay for Altiplase. Other centers where the drug Altiplase has been going on for a long time, and they have the National Health Services or the government is funding the hospitals. Again, there is resistance. And as Dr. Ichapuria has said, that we are the leaders. Actually, it is by default. It is basically because of the price. And although most of us were very skeptical in the beginning that you have introduced a drug without a trial being done, and how did you even get permission from the Indian authorities? And yet it has picked up, and it has picked up very much. And the trials retrospectively are showing that we were not wrong. Or the company did do that, but it has picked up definitely, and it would pick up more and more. And even some physicians in the periphery, those who have access to a CT scanner, even at the taluka level, tehsil level, they are phoning and asking whether tenecteplase can be given, and they are giving. So it will pick up even more. And one last thing is, there is another company which is bringing out which has already brought out a biosimilar tenecteplase. I have no experience. Does anybody have any experience with that? I forget the name.
There are a number of companies,
There are as of now 3 companies,
but they've not promoted it. There are a number of Abbott has got a molecule. Many companies, and they are using it for cardiac patients. But somehow and it's a 30 milligram vial, so they have not promoted it for stroke. But there are many tenecteplases in the market, many biosimilars. So they are there, but somehow they are not promoted it. And I was talking to the Boehringer people. They said that they don't have enough capacity to make tenecteplase in Germany. That's what they said. Now, I really found it hard to believe, but I don't know why they are resisting so much. And as you said, unless it becomes level 1A evidence, the insurance companies in the Western world are not reimbursing it. So therefore, we have to wait. I mean, I think now this ACT trial is there. It should come up from 2B. Definitely, it should come up to 1B or 1A also. I see no reason why it should not come up to 1A. If it comes up to 1A like Altiplase, then the insurance companies should have no hesitation.
Can I add, sir, one point here?
Yes, sure.
Dr. Swami here, sir, from Ampure. Sir, we did 2 studies, sir, and for the approval of tenecteplase. One was dose escalation study, where we compared 0.1 to 0.2. And after submission of that data, DCJ again asked us to do a study with 0.2 milligram per kg, which we did. And then we published that study, both the data, in American Journal of Cardiovascular Drugs in 2018.
Yeah, I read that article. But you have to do consecutive cases, not selected cases. That's the problem. So, acceptance of that paper becomes a little difficult. So you have to do a little better design. And, now you've got 30,000 patients.
So
how many have you got? By the way, tell me the exact figure.
Every monthly we get 1,200 patients. Every month.
1,200.
Every month.
5 years ago we were doing 1,200 per year.
Yeah.
Now it's 1,200 per month. So it's a giant leap. And I wish it goes on. And I used to give a lecture, and that time we had shown that 1,200 only were done in a year. And now if you've got such heavy data, you must publish it.
We can
become the world leaders, Dr. Swami. we can become the world leaders in this. And why not? Why are we so diffident? Why are we so this thing? We've got so much data, amazing amount. I don't think any country has got that much data. This ACT study was 1,000 patients. Here we've got 1,200 per month. Even if you publish for 6 months, you have enough data.
Yes.
And nobody can then refuse it.
We are working, sir. Our 730 patient data is already ready, which will go into the public.
Yeah. So I think let's work on that, because it's very exciting. And really, we want India to be a world leader in medicine also. Why should we only follow the West? So we can be, and we've shown that it is good. So let's publish it and, get on with it. Okay. Thank you, General Narayanan, for initiating this very lovely discussion. And as usual, we have gone over time, like we always
thank you, sir.
do.
I'll excuse myself if you don't
Yes.
Thank you so
Please
much,
enjoy the evening and have a good drink or two and cut a cake also.
Thank you so much, sir.
Thank you, sir.
Okay. All the best.
Thank you, General Sir.
Yeah. Tanmay,
Yes.
it's so nice to see you. And, we want so many young people to take part in this and not oldies like us all the time. So we are really very, very happy to see you. And if you could present your case, it will be nice.
So I'll share my screen. Actually, my case is a very simple one. We had a 70-year-old male patient without any known comorbidities. He was a chronic tobacco chewer. He presented to us with right-sided upper and lower limb weakness with difficulty in speaking, which started around 3:15 p.m. on that particular day, which was so he presented within a window period of 20 minutes. When he came, he had hypertension as an accelerated hypertension. BP was 200/100. Pulse rate, respiratory rate, saturations were all within normal limits. His systemic examination showed right-sided partial gaze palsy, right-sided upper motor neuron facial palsy, dysarthria, right hemiplegia. If I calculated on an NIHSS, it was coming to 18. His other systemic examination was otherwise normal. I did a CT. The CT did not show any bleed. There were old ischemic changes as in the external capsule and in corona radiata in thalamus, but no acute hypodensity and some cortical cerebral atrophy. He came to hospital within a window period of 20 minutes. He is, because of accelerated hypertension, he had to be treated with labetalol to get the BP down to the level at which we can thrombolize. So after about 40 minutes of door to needle time, he was thrombolized with tenecteplase with 16 milligram of tenecteplase at around 4:15 p.m. So with so much of 40 minutes of gap, the initial NIHSS of 18, I was not expecting to have a complete resolution of his all symptoms. So at 1 hour of post-thrombolysis period, there was partial resolution, but by 3 hours, there was complete resolution of all his deficits. There was no pronator drift left, no ataxia, or even the speech had completely improved. The repeat the angio was done post-thrombolysis, and that did not show any occlusion. There were hypoplastic cleft vertebral arteries and fetal origin of PCA, but otherwise anterior circulation, there was a hypoplastic anti-communicating artery, that's all. Within the next 24 hours, he had still hypertension was there, so he needed labetalol intermittently. The repeat repeat CT scan showed same changes. So there were no new hypodensity as well on the repeat CT. I could not do an MRI to see whether there was any new infarct, which probably may have picked up on MRI compared to CT at that moment. But at least on the CT, there was no bleed. Later, he was started on antiplatelet. And even in the next 2 days, he was completely all right otherwise. So, so the point of this was that, even though the score at the onset, NIHS at the onset was on the side of a higher score as in 18 with little prolonged door to needle time, there was still a complete recovery for him from his baseline. In past 1 month, in the month of August, we had around 6 cases where patients were thrombolized with tenecteplase only, all in the range age of 60 to 70, and their window period of presenting to the hospital were ranging from 20 minutes to 1.5 hours. There were door to needle time, I think, could have been improved in many of the cases. Some they were delayed because of, as in this case, BP being high, and some still we need to go to the relatives to a level where they need to be convinced that there is something which can be given for a reversal without much risk of bleeding. So out of all these cases, those which had a large vessel occlusion, as in the case number 3 where there was an M1 thrombosis, and case 5 where was a right M2 thrombosis, those were the cases where even after thrombolysis with tenecteplase, the improvement was not very significant, as in the score improved from 24 to 20, and from the second case it remained same from on day 3, though on follow-up on second week it had slightly improved. But other cases there was significant improvement in the NIHS on day 3 of their follow-up and on 2 weeks follow-up. This was the case where though the NIHS was high, there was an almost normal complete resolution of after the thrombolysis on the same day and remained the same on follow-up. The cases where there were large vessel occlusion, those are still in, as in I have to follow them up later to see whether there is a 1 month or 90-day improvement. But the others which were initially thrombolized are better than the initial immediate post-thrombolysis stage. No, that's all.
Yes, Dr. Pramod, would you like to comment?
Yeah. Yes, so I think that's a very gratifying result to have a NIHS of 18 and then resolving completely within 3 hours. I think among the 6 cases that you present, that you have in your table, I think that is one patient where the presentation was very early. I think within 30 minutes he was in the hospital, isn't it? And your door to needle time is also around total 40, and that's because of the need to control the blood pressure. So I think that's among your 6 cases, that is the one where you have the earliest presentation and the shortest door to needle time. So that I think has played a major role in that resolution. So yes, it does happen, not often that you get this kind of a dramatic result, but it is, when it does happen, it's very, very gratifying. And the effect on the whole patient and family and on your own confidence is tremendous when you see that kind of a. But I think it's good that you're able to. You did 6. That's a very good number, and to do it reasonably quickly. I think there's some patients that little delayed, but I think otherwise you're managing it quite well. So for this patient and all your other patients, I totally commend you.
Thank you.
Yeah, Dr. Gajre?
Well, nice to see a young lady doing such good work. And I wanted to comment on the same point, but doctor has already commented, so I don't see any reason to repeat it. The only thing is that in large vessels, my experience is that tenecteplase is better than alteplase. That is my experience, but my experience with alteplase is much less as compared to tenecteplase. What do you think, and what does the other panelists feel?
For LVO?
Hello?
I think for LVO, the drug of first choice should be tenecteplase, because if you see that trial done by Bruce Campbell, what's called the Extend 1A trial, at 1 hour, there was recanalization in LBO of 28% compared to 16 or 17% with alteplase. So there's a distinct edge though it's a small trial, it's early days, but there is a general signal that it's good. And this is a very, very important point that there was a movement in the very recent past that straight you take these patients for mechanical thrombectomy, LVO patients. But I think now the trials are very clear that there is no advantage in doing that unless you can take the patient very, very quickly, or if there is a contraindication to giving IV thrombolysis like low platelet count or recent surgery or recent bleeding. There is no advantage in not giving a thrombolytic agent. So the trials have clearly shown that giving a thrombolytic agent increases your success rate of mechanical thrombectomy. And I've seen this repeatedly, many, many times, that many patients who have LVO with IV drug also, it opens up. So it is not true that every patient will need a mechanical thrombectomy. Many such patients do improve, and in a resource-restricted country like India, I think we must give it. And especially if we are doing the drip and ship method, or giving the drug and then sending to a stroke center, definitely we should give IV thrombolytic agent. Tanmay, I have a few questions about your case. First question is, whenever you do CT scan now in the future, try to do the aspect score, because it's a little difficult to do it on the CT scan, and you have to train your eyes and mind to do it. It's a little difficult, but the more you do it, it will give you very good information. Now, from what I could see very quickly in your case, the aspect score was very good. It was probably 10 only. So when you have a good aspect score, and very quickly you have given, as Pramod said, very, very quickly you have given the tenecteplase within 20 minutes. I think extremely creditable on your part to do that. Another thing which I think you should do is, no case you should let go without doing a CT angio at the same time. I don't know why you did it later. I couldn't understand why you did it later. So you have to do the investigation now is CT scan followed by, if the CT scan shows good aspect score and no hemorrhage, give IV thrombolytic agent in the CT scan department, and then in the next 5 minutes do a CT angio. And the CT angio should be 3-phase to show, it should go up and down and up. So you have to, it's not just one way. It has to go up and down and up. So you see the flow in the blood vessel over 3 seconds, or maybe 4.5 seconds, because it's 3-phase, and that will show you the collaterals. It will show you the length of the clot. It will show you the density of the clot, and it can give you a tremendous amount of information. So please do it. I think in your case, from what I could make out, it was, though the NIHSS was so high, it was a lacunar stroke.
Okay.
And there was a lot of confusion in the past that lacunar strokes, because of lipohyalurolysis, you should not, TPA does not work, but it works. It works. And lacunar strokes given TPA do better than lacunar strokes not given TPA. There is clear evidence that it is useful, and you said patient was not hypertensive. He was not.
Previously,
so, then, but then, probably he was not a known hypertensive. He was not a known hypertensive. So, but probably he had hypertension and he had a lack of stroke because his BP was high, and you had to give him labetalol and you had to keep the BP down. And I think you've done very well, and the patient's family will bless you for as long as they live, because to see a patient with NIHS 18 and in the next few hours becoming 0 is what we call the Lazarus Effect. And this is called, what is that called? Very early neurological improvement. Very early neurological improvement that occurs in about 20% of cases. And when you get that, and you do get it, you get it in 20% of cases. And it's a miracle. It's like as if Lazarus has, come up from the grave. He was pronounced dead, and now he has come up from the grave. So that is why we call it the Lazarus Effect, and also called VENI, very early neurological improvement. And it is one of the most gratifying things. When we had cases like this, people said, "Hey, you thrombolized a TIA." They say all sorts of stupid things. But then the answer is, my answer to them is, I converted the stroke into a TIA by giving thrombolysis. So what do you have to say to that? So, there are many naysayers. There are many people who want to say things which are unpleasant to you. But we've been through all this nonsense. And if you see a patient with a deficit, it is not a TIA, it is a stroke. A diagnosis of TIA is made retrospectively. It cannot be made prospectively. If you see a person with a neurological deficit, it is a stroke. And by giving TPA, if he has improved, you have converted a stroke into a TIA. So that is great credit to the treating doctor, and you have to take credit for it. It's not natural occurrence. You have to take credit for it and say, yes, I've converted this stroke into a TIA and I've helped the patient, and it is really a fact. So these amazing cases occur, and as Dr. Kajri said, it must have boosted your confidence, and therefore you could do 6 cases in 1 month, which is excellent, and your door-to-needle time was very good. And because your door-to-needle time was very good, therefore you are getting such results. So congratulations to you, because I think you've organized a good stroke team, and you've been able to do it at all times of the day and even on holidays. And that is because of a stroke team on a code stroke. Probably you have a code stroke in your hospital. Do you?
Not yet.
Then you better start a code stroke where, you announce, and, everyone runs, and if they're eating food also, they drop the morsel, and without washing their hands, they go and see the patient. So that is what a code stroke does. So you should get this code stroke incorporated into your hospital public address system, and do it so that your door-to-needle time comes down. And take it from me that door-to-needle time is the most important thing. You get your door-to-needle time to 15 minutes and 20 minutes and 30 minutes, and you see the dramatic change in your results. From a degree?
Yes, sir. Absolutely, sir. Yes.
Yeah. I'm sure you've experienced that, and I'm sure you have incorporated that in your hospital.
Yes,
and, it gives you some amazing results. And, people don't believe it, but it takes effort. You have to get those administrators to move their bottoms, and, that I found that the most difficult, to get the administration on board. But once you get them on board and you do 6 cases a month, then their eyes pop out, and then they'll do anything for you. So, sorry to be so blunt, but that's how life is. And you show good results, and you get more confidence, and you can do much better each time.
Just one point. Yeah, one point. This is all the more reason that if it is definitely better to give it before mechanical thrombectomy, which I personally feel is right. But then the data which this company has of so many thousand cases, somebody has to analyze it and really.
It's analyzed, Sunil. There is a proper trial now. Proper trial to show that giving IV thrombolysis prior to mechanical thrombectomy is better than doing direct mechanical thrombectomy. Unless you can do it in the next few minutes, which very, very few centers can. Or unless there is a contraindication.
Place people analyze their cases and also give us more data.
No, there's data on published data. There is published data now. There is no need for company to give you anything. It's published, it's in the public domain. And there's absolutely no doubt that thrombolytic agent prior to MT is better than doing MT directly.
That's a logical thing to do, to give it before.
Yeah. No, but there was a lot of argument on this. No?
I saw the arguments in stroke and the ISA section, Indian Stroke Association section of the MAN group, Maharashtra Association Neurology Group. These people who are doing the thrombectomy, they will always push for doing thrombectomy because they are doing it and there's money involved. But the ideal thing would be to give the drug. More so, the door-to-needle time is there. You give the drug. If it fails, then go ahead and do the thrombectomy. That looks, and that's it. That is reasonable.
No, you don't wait for it to fail. You give it and you shift the patient to the cath lab if you can. So you don't wait for improvement. You just shift the patient and then you do an angio. And if the angio shows that it's recanalized, finished, work is done, or then you do the mechanic. But don't wait for the improvement, because how long are you going to wait? Half an hour, 45 minutes, 1 hour, 2 hours?
An hour.
No waiting. If it is a LVO, you give the IVT, and if you can shift the patient quickly to the cath lab, do it. Don't wait.
Yeah, that's true.
Because even that is very time sensitive. You have to do the groin puncture within 6 hours.
We will not wait. The patient should be willing to spend so
all that takes time, no?
Same thing.
In our setting, it takes time. So that's why I'm saying this is in an ideal situation. Our situation is different because money is involved. And large sums of money are involved. And expertise, sometimes you can't get the interventionist in time. He's busy somewhere or he's far away. So the cath lab is occupied by the cardiac people. So there are roadblocks, but somehow we have to overcome them. And unless we do that, our results will not be good.
Yes.
So there are roadblocks, but you see, these are not roadblocks. I would say they are speed breakers, and they slow you down. And because they slow you down, your results are not good. But if you do it properly, I think it gives good results. And you have to gear up the entire system. It's not easy. To do mechanical thrombectomy requires 20 people. 20 people. Anesthetists, radiologists, ICU staff, emergency room staff, the interventionist, the neurologist, the resident doctors. It requires 20 people. So it's a high cost, high intensity treatment. I don't know, sometimes I really wonder whether it's suited for India. But for certain pockets of India, yes, it is suited. But across the board, still the jury is out. Pramod, what do you think? In a big city like Bangalore, with all its traffic problems and waterlogging and this and that.
It's a challenge, sir. But I think most administrators are happy when you produce good results and then they are ready to back you. So we have a code stroke that goes to the interventional radiologist, ICU, cath lab, the radiology department, along with the neurologist. So the person is alerted as soon as the patient enters the ER. And if it's not a large vessel occlusion, then we inform him that no, it's a false alarm and you're not required. But otherwise, he's alerted at that time itself. And so usually they turn up. They all stay nearby. We have 2 of them. So one of them will manage to turn up. But in spite of all the best efforts, there will be some delay, anesthetist or some technician or some technical issue. It does happen. But since we keep doing the same thing now, it's a little bit streamlined and everybody knows their role and when they need to step in. And cost, the discussion of cost starts off as a patient is going through the CT and thrombolysis. We're talking to them that if the CT shows this is what we're going to do. And if the angio shows this is what we're going to do. And this is the kind of cost that you can expect, so that there's minimum delay in obtaining their consent. And if the patient is really having financial challenges, then it's a problem. We get held up because we have to speak to somebody else and their relatives and their relatives. But most of the time, I can't remember a patient who declined either thrombolysis or thrombectomy because of financial reasons. I think almost everybody eventually agree when you convince them about the likely benefits. And our job is to select the right patient and not do it for the sake of doing it, where the results are likely to be poor. So once we select well and convince the patient that it is the right option, a huge majority eventually fall in line. And we've had the administrators backing, because definitely it adds value to the patients, to the department and the hospital's role in providing care. So they like to have that additional profile to be maintained, that yes, we are stroke ready and we can deal with all types of strokes. So I think we have to convince them that it is about the profile of the department, the quality of care that we're providing, and the real medical value of the therapy. And I think then and of course it's a positive financial part also. The hospital is happy that it brings in money also. So I think eventually they agree. And as Sir said, a big team is required. So that is the challenge, getting the right people to be available all the time. But it can be done in some centers, sir. But it's difficult to replicate everywhere.
Yes, Pramod, absolutely brilliantly put. Every single word you said is absolutely correct. And you know what you could try? I mean, we've had this major problem of money. Finally, we were able to convince the administrators. And now we don't need to take permission for money. And what we found is 95% of people will pay. And the hospital has said that, okay, if 5% don't pay, we'll write it off. But as you said, 95% somehow or the other, from some source or the other, even now you get EMIs and, through Bajaj Finance and other finance companies. And so there are methods. So now, we've had this money issue for a long time. But now we've been able to convince the administrators that, yes, and the CEO has told us, just go ahead. And if there's a 5% loss out of 95 patients, I will bear it. So maybe you could talk to them, because, many people, and we also had this major problem. So we can surmount it. And for IV thrombolysis, hardly anyone has refused.
Yes, sir.
Hardly anyone. So yes, in certain pockets of India, it may be difficult. I do agree. But at least in urban areas now, IV thrombolysis has become very easy. MT, there are challenges, but we are facing them and we are overcoming them. So let's not be nihilistic. Let's be positive. It can be done and we should do it.
Yes, sir.
Yeah. Tanmay, you want to say something?
It was definitely
Don't be shy. Huh?
It was definitely a good feeling when I had that definite improvement after the case. That was the reason I thought of presenting. Otherwise, it was a very simple case to do.
Nothing is simple. Nothing is simple. You made it simple. Nothing is simple. To give thrombolysis in 20 minutes is not simple. To give labetalol and bring down the BP in 10 minutes is not simple. It takes effort, it takes judgment, it takes guts. So it's not as simple as you are making it out to be. I know the roadblocks which are there, but because you do it well, it becomes simple. So I think we've had a very beautiful and lovely discussion with Dr. Sunil Garcia and Dr. Pramod Krishnan, and of course Tanmay, and all of us. And we are, as usual, over time. That is usually the case, but we can go on for hours and hours. So any last words from Sunil Garcia and Pramod?
Well, really nothing. Everything has been discussed. I thought there was another case also. Is there another case?
No, sir.
No. Now enough, man. It's 9:45, man.
Yes.
I'm feeling hungry now.
Just one question. Dr. Krishnan is from Nimans, is he?
Yes, sir.
Dr.
I did my DM from Nimhans, sir.
When did you pass out?
2011.
Oh, right. Anyway, nice to know that you're from Nimans, and I read your CV, best outgoing student, all that, great. And you work in Bangalore, do you?
I work in Manipal Hospital, sir, Bangalore.
Okay, right. That is that hospital near the old airport.
Yes, sir.
Okay, because in our times in Nimans, the old airport was there. There was no new airport.
Yes.
Right.
The only thing, sir, is in our curriculum, for example, in my 3 years of DM in Nimhans, there was one thrombolysis done. That's it. Just one thrombolysis. So if one thrombolysis was done in 3 years in Nimhans between 2008 to 2011. So I think that, sorry, sir.
Why so less?
They were not ready to start the program, and they felt they would be deluged with patients, and they don't have the required manpower to handle the huge influx and that and this. It never happened. So I think that was very unfortunate that, and only recently, I think only maybe the last few years, we have more consistent thrombolysis happening. And I still think the numbers are low from what I understand. So I think that's the thing. Some of the big hospitals, big centers, probably not, I don't know whether it's a staffing issue or what, but it's sad that it's not just the periphery. Sometimes some big setups also miss out on doing their fair share of thrombolysis and procedures.
No, as I told you, Pramod, less than 50% of neurologists are doing thrombolysis. I don't know why. And there are now more and more physicians doing it. And I've heard this Niman story, and it has saddened me no end, to hear that, such few cases were done. And, these were the roadblocks I was talking about. These are all pseudo roadblocks, and these are all mindset. If you want to do it, you can do it. Anywhere you can do it.
The mindset is the main thing. We have discussed why one faculty member was so against it. If you remember the discussion, one faculty member was saying that it is useless and it is not worth it. Anyway, that's a different story.
Yeah, I had a big fight with him.
Yeah, and I won't name the faculty member. But anyway, that's
that's how it is, unfortunately. But I think we've got over that, Sunil. Now we've got over that.
Yeah.
That was a hump. We've got over that. It was unfortunate that, when Pramod, when you were a student, you didn't do it. But you've made up now. You've got up.
Yes, sir. Yeah. So every thrombolysis related training has happened actually outside after I started practicing. Yeah. And then
so you have to reinvent yourself every day.
Yes, sir.
Okay. Chalo, I think we'll call it a day.
Yes, sir.
We hand it back to
the final words. Thank you so much, everyone. What a great evening we've had. And as sir mentioned, as usual, we've gone past the scheduled time for this meeting. More than 150 doctors have joined us live for this evening today. And I would like to thank all the audience who have joined us this evening. I would like to thank the speakers, Dr. Tanmay and Dr. C.S. Narayanan, for coming forward to share their presentations and the cases with us. I would like to thank Dr. Pramod Krishnan and Dr. Sunil Gargia for being moderators for this evening today and sharing their experience on the two presentations. And last but not the least, sir, thank you so much, Dr. N.R. Ichapuria, sir, for constantly supporting us and guiding us on this initiative. We'll meet again next month with another set of cases on thrombolysis. Thank you so much. Good night.
Thank you, sir.
Good night, everyone. Good night. Bye.